So I would like to introduce our moderator for today's session. So it gives me great pleasure to introduce Ms. Soffi, a senior optometrist at Anpur Eye Hospital. So she is a distinguished alumna of Dr. Agarwal's Institute of Optometry and a gold medalist of C18 batch of DAIO, reflecting her academic excellence and commitments to the profession. So Soffi currently serves as a clinical optometrist, providing comprehensive primary eye care to patients, and her expertise includes diagnosing ocular conditions, then appropriate diagnostic scans, and assisting doctors in both OP and OPD procedures. So, with very precise accuracy and care. So, beyond her clinical competence, she is deeply involved in community outreach as well. So, her passion for knowledge sharing extends to a digital space, and she has an experience in writing content for hospital websites, and she is actively engaged in social media and YouTube. So she also showcases her keen clinical observation by capturing and sharing interest on anterior segment cases on social platforms and contributing to peer learning. So please join me in warmly welcoming our moderator for today's session, Ms. Soffi. So welcome you, Soffi.
Thank you, ma'am.
Thank you. So, and we have a presenter for today, Ms. Sonali Mahali. So, welcome you, Sonali. So, you can start projecting your presentation.
Yes, ma'am. Good evening, all. Thank you so much, Matagi ma'am, so giving me this big opportunity, and thank you so much, Sophie ma'am, so also helping me throughout my all hustle,
Thank you.
and
Thank
I'm
you,
really
Sonali.
thankful today. This is my really first time, ma'am. So I hope you understand, ma'am.
Yeah, I understand. Yes, Sonali, can you start?
Okay, ma'am. So today's topic is central serous chorioretinopathy. The case history: patient A. The age of the patient is 32 years old. Gender is male. His chief complaint is blurring of center vision in right eye since 1 week. And when we are taking history, it's high stress. Uses topical steroids occasionally. Ma'am, next slide. No history of trauma and any systemic illness. Vision assessment: visual acuity in right eye 612 and left eye 6.6. When we are doing Amsler grid, the patient says his central vision is distorted in right eye and normal in left eye, and also the contrast sensitivity mildly reduced. Next slide, no? When we are doing his slit lamp, the anterior segment is looking normal, lens is clear, fundus examination after dilatation, service detachment of macula, RP changes, and no hemorrhages. This is the slit lamp photo of CSCR. We can see there. Investigation advice for the patient is OCT, also the FFA, OCT angiography. It's optional, and blood pressure evaluation, because sometimes pressures also cause to the CSCR. This is the normal eye, and this is the CSCR eye, where we can see the some fluid in the retina. Next slide, ma'am. Investigation finds OCT, dome-shaped serous detachment in the macula, as we can see in previous slides. FFA, in dot leakage pattern seen, no CNV detached, and BP mildly elevated. This is the FFA image. There we can see the CSCR clearly. Diagnosis: central serous chorioretinopathy in right eye. This is the acute CSCR. Explanation of the condition: CSCR occurs when fluid leaks from the choroid and collects under the retina. This causes central vision distortion. Stress and steroid increases choroidal permeability. Most cases resolve spontaneously within 2 to 3 months. In acute cases, they are resolved in 2 to 3 months, but in chronic cases, they may require treatment. Like next slide, no? This is CSCR and normal picture again. Introduction. Serous chorioretinopathy is a retinal disorder characterized by a serous detachment of the neurosensory retina, common in young to middle-aged adults, often associated with stress and corticosteroid use. This is a complete picture of and 3D image of CSCR. Epidemiology, more common in males, 8:1 ratios. Age 20 to 50 years, risk factors, stress, steroid use, hypertension, and pregnancy. So most common cause of CSCR is stress and steroid use. Pathophysiology, hyperpermeability of choroid vessels, dysfunction of retinal pigment epithelium, leads to fluid accumulation under the retina. Here we can see that there is a fluid seen in the retina. Symptoms: blurred central vision, metamorphia, that is distortion vision, micropsia, object appears smaller, central scotoma, reduced contrast sensitivity. These are the symptoms of CSCR. Management and treatment: observation for 2 to 3 months for active CSCR, discontinue steroid, stress management. If persistence, then only we need laser photocoagulations, photodynamic therapy, and anti-VEGF injection in selected cases. Prognosis generally good. Recurrence possible in 30 to 50 cases, 30 to 50% cases. Chronic cases risk RP atrophy and permanent vision loss if they are not treated. Thank you. Thank you so much. Thank you, Soffi ma'am.
Thank you, Sonali. Thank you for this wonderful presentation. Over to you, Sonali ma'am, to discuss more in deep about the condition. Over to
It was
Soffi ma'am.
indeed. Am I audible?
Yes, you're audible.
Okay, it was indeed a beautiful presentation, well put, with a neat and understandable case for our present speaker, Ms. Sonali. Great job. So whenever you consider something like a chorioretinopathy, so whenever you consider a term chorioretinopathy, this covers almost a range of disorders that affects both choroid and retina. It can be due to various causes like inflammation, genetic disorder factors, or systemic disease, etc. Today, we got a chance to see most common condition which we all would encounter in our clinics, that is CSR. Um, in any case, I would always insist that in any disease condition, it's very important to understand the pathophysiology because this is only going to make a clear picture of how this condition manifests. So here, no, the choroidal vascular vessel hyperpermeability and the RP disturbance are the cornerstones of the condition. When you take the RP disturbance, when there is any micro defect in the RP, it is going to change or hamper the barrier function. So the choroidal fluid crosses the RP, leading to neurosensory detachment. Generally, RP does not allow any fluid, but when there is a loss of polarity, due to this, pumping is reversed and fluid is directed towards the subretinal spaces. So when you want to address your case towards the right diagnosis platform, as a clinician, I would suggest undoubtedly, I would also put full of my focus towards getting a detailed history from the patient. So because with proper history taking, we optometrists can definitely come to a tentative diagnosis. Like history taking is always a crucial part in diagnosing any condition. I would suggest you all to focus on sectors like patient's chief complaints. Not just asking a question to the patient is going to cover the chief complaints. You have to always probe a little deeper to elicit the exact symptoms which patient experiences, but is unable to properly put in words. For example, when the patient says it's like a blurred vision, add on questions like if the patient experiences it unilateral or bilaterally, is it constant blur or it is just on and off, or it is localized to a particular area or it is generalized blurring motion, any sort of distortions associated when along with the blurriness, or any change in color perceptions. Because all these additional information would help you to drive towards a certain add-on investigations at your chamber. So not just your chief complaints is enough. Then what more to add is know your patient even a little more. How to do that is just observe the patient from the time they enter your chamber, the way they speak, make eye contact, ask about their occupation, lifestyle, etc. Because when you pitch these questions in the middle of your chief complaints, you would also get some of the additional details for your diagnosis. There are other diseases with similar symptoms and subretinal fluid, such as some neovascularization disease or VKH syndrome, optic disc retinopathy. So, a thorough clinical examination, a multimodal imaging like OCT, fluorescent angiography, ICGA, plays a further role in specifying the condition. On examination, it is really important that you get also, you would get a clue like there will be a temporary hypertrophic shift, and this condition would definitely likely to affect young men, like from the age of 20 to 45 years. And also, you know that one research found that there is a relationship between CSCR and a type A personality. Because type A personality persons are aggressive, competitive, and have a sense of urgency. So what happens is there it causes release of catecholamines, which increases the choroidal hyperpermeability that also comes as a pathophysiology. So also our CSR is associated with systemic intakes of corticosteroids that could be either oral or intravenous. So as an optometrist, I would suggest all the fellow and budding optometrists to drive yourself towards accurate history required and go towards appropriate diagnosis. For example, you get a case like when you say a patient says there's a metamorphopsia, just take an Amsler from your table, give it to the patient, and you see all the slit lamp findings to be normal and the Amsler findings seem suspicious. Drive the case towards taking OCT. When subretinal fluid is evident, make a prompt referral. You know what? Because of our prompt referral, will be definitely significant to further manage the condition by the ophthalmologist. Also, ensure to counsel the patient in both sympathetical and empathetical approach because patients of any condition carries more hope when they sit right in front of you. So your words are not just words; those are phrases that are carried by one who already carries a lot of anxiety. You have to communicate and build a rapport with the patient in such a way that the next time when they approach your clinic, um, even just for a general checkup, they should be like, I want to get my primary examination with the optometrist with whom I have just consulted on the last visit. So this is how you have to build a rapport with your patients. Also, I would just leave here with a to be continued note that I insist every one of you to read about the recent advancements that is happening in our CSR diagnosis and treatment. If your minds are just hunting for knowledge and is curious to know about it even more. And that's from my side. I wholeheartedly thank Dr. Agarwal's Institute of Optometry for once again considering me to moderate a wonderful case. Thank you all. And remember, hunt, just hunt for knowledge. There's a beautiful saying in Tamil you all might know, right? கற்றது கைமண் அளவு, கல்லாதது உலகளவு. There is no end for learning, so just keep hunting for your knowledge. Thank you.
So thank you, Sophie. A very nice saying at the end. So very sweet of you. Thank you so much for accepting to be the moderator for this session, and thank you for your wonderful insights on the topic. And students, if you have any questions, you can feel free to ask questions or post it in the chat box. Or if everything is clear, can we have a thumbs up?
Thank you so much, ma'am, for once again considering me to moderate your session.
Thank you so much, Sophie. So we'll end this session here, and thank you so much for the moderator, and looking forward for many more sessions with you. And thank you, presenter Ms. Sonali. So thank you for the wonderful presentation as well, and thank
Thank
you
you,
for the
ma'am.
insights and
Actually, ma'am, I thank you for considering me for the presentation, because this is really my first time, and Sophie ma'am really sweetly guided me throughout my all the presentation. I'll share with my experience with her whenever when I was starting my presentation, and she sweetly guided me. And thank you, ma'am, because of you today I present my presentation. Thank you so much, ma'am.
Thank you, Sonali. So one of
Thanks a
very
lot.
active extern of DAIO. So whenever we have a case presentation or any online series, Sonali is a very active person in that, in raising hands and clearing our doubts. So thank you, Sonali, for that. And
Yes, ma'am. In future also, I would like to join presentation.
definitely. There are
Thank you,
many
ma'am, giving me
presentations
the big
happening weekly and
opportunity.
very monthly. So we will definitely post you on presentations. And thank you, Sophie ma'am, for moderating the session, and for accepting to be the moderator for this case presentation. And we are looking forward to many more sessions with you, ma'am.
Thank you. Thanks a lot.
Thank you all, interns and externs. So we will meet you all in next Friday class. Thank you all.